Welcome, my dears. A new part here in our own curriculum about dementia and the gentle persuasiveness approach, gentle persuasive approach. Here we got the module 3 right now, and we will start the module 3. Module 3 is talking about how to deal with the different kind of behaviors, different types of behavior for the dementia cases, how to deal with the different types of dementia behavior. People, like the people with dementia, they might behave in different kinds of behavior. They might be agitated, they might be nervous, especially we talk about this when we're talking about the sundowning. And we said in the sundowning, they become like very agitated or angry and change the mood. Also, they might change from very easygoing into another person, which is more hard to deal with. This is another point. So in that cases, what shall we do in cases like this as personal support workers or as healthcare givers? What we will do in such situations? Just let me quickly remind you with what we said before about the dementia behaviors. In the early stages, like you see here in this chart, let's go to this chart right now. So in the early stages, difficult with balancing households, budgets, planning and organizing, managing medications. These are the symptoms of the person who has dementia. And what is needed in this stage is cues and pointers will then be needed to help the dementia-driven individual stay as independent as possible for the longest durations. In the middle stage, they have difficulties with communications, and the conduct of the routine living activities becomes all the time difficult. And in that case, the caregivers or the personal support workers will have to be more intervening and supporting the dementia cases. In the early stages, dependence is almost zero. In the middle stages, it's in between dependent and independent. I mean, the cases. In the late stages, it's 100 dependent. The dementia case or the dementia client or the dementia patient is 100% dependent on the personal support worker. The required here incrementally greater level of care and support. So here there must be interfering to support, more support to the client or the patient. In late stages, there are a lot of difficulties with fully lose their ability to communicate, problems with eating and swallowing, the dysphagia as example. So you have to cut, like we said, cut the foods into small pieces. Susceptible to infections, and most notably pneumonia. That is what we talked about before. Now, we came to the part of physical contact with the personal support worker. What shall a personal support worker do in different types of behaviors? In the different types of behavior that's happened from the dementia case, especially we said dementia cases, they don't have a same root in behavior. The behavior change from a good mood into a bad mood, from peaceful into very agitated, abusive, and aggressive person. Changing the behavior in the sundown when the sun is down, and they start to, because maybe they are feeling the dark, fear of the dark or whatever. The hallucinations and delusions and delirium as well. Delirium and all these aspects also make them more like his example is saying, I can see someone is watching me, or I can see and there is no one. Also changes in the behavior in that he's trying now to be socially isolated. He or she would prefer to be away from the people, even from their beloveds. They lose their interests in doing things. They are more to sleep. Sleeping times are more and more. And that is some things. You might forget in the late stages how to eat. You might forget So this also the communication, there's problems in communication. He's very slow down. He's repetitive, repeat the words back and back many times. So everything has a strategy to be done by the personal support worker. And we said this parts in the previous parts. We talk about how to deal with the different cases. What are the strategies that the personal support worker should do in each stage of the 3 stages of dementia? In the early stage, in the middle stage, and in the late stage. What shall he do? Shall I go right now into, actually, this video is very important because I just want you to see it. Actually, I just want you to see this video. It's very, very important piece.
If you're caring for a person with dementia in unexpected or inappropriate ways, these reactions are called responsive behaviors. And although they can be confusing or even scary to see, it's important to understand that they're happening for a reason. In this video, we'll look at some of the most common types of responsive behaviors and give you a few strategies for how to deal with them. A responsive behavior is a reaction to something that the person you're caring for is having a hard time expressing. When a responsive behavior happens, remember that the person you're caring for isn't trying to be difficult, they're having difficulty. Even though it may be hard, try not to take their words or actions personally. They're directed at the situation, not at you. Responsive behaviors can show themselves in all sorts of ways. Sometimes they're verbal. The person you're caring for could yell, curse, or call you names. Other times, they can be physical. When it comes to dealing with a responsive behavior, your own safety is key. If you feel like you're unsafe or in danger, don't be afraid to leave the area. The most helpful way to control or stop a responsive behavior is to figure out what's causing it and try to remove the trigger. Although it may not always be possible to understand the cause of a responsive behavior, shifting your point of view is a good place to start. Let's take a look at some of the most common types of responsive behaviors and the best ways to help manage them. Agitation is a responsive behavior that can involve fidgeting, wandering, picking at one's clothes, or general restlessness. If the person you're caring for seems agitated, try giving them something to hold, distracting them with conversation, or taking them for a walk. Ask yourself if they're tired, too hot or cold, need to use the bathroom, or if the noise and lighting levels could be making them uncomfortable. Don't tell them to calm down or stop what they're doing. Sexual behavior is another common responsive reaction. This can be distressing to witness, especially for young caregivers taking care of a parent. People with conditions like dementia have less control over their urges and often don't understand social norms. Although you may find their actions shocking, as long as they aren't hurting anyone, you should try to give them privacy and avoid scolding them. If privacy isn't an option, like when you're helping them bathe, try to distract them by giving them something to hold, like a washcloth or shampoo bottle. Sometimes what you might think of as a sexual responsive behavior is actually something else. Perhaps their clothing is too tight, they're too warm, or they need to use the bathroom. Look for possible triggers and do your best to remove or adjust them. Another common responsive behavior is repetition. The person you're caring for might ask the same questions over and over, or repeat the same words or movement. This can be difficult to handle as a caregiver, as they may be asking about a loved one who they've forgotten has died. Try to think of things you can do that can help soothe their emotions, like reminiscing, looking through photo albums, or distracting them with a conversation about another topic. Avoid telling them to stop or reminding them that their loved one is deceased, since this can start the grief process all over again. Hallucinations and delusions are also responsive behaviors. The person you're caring for may begin seeing things that aren't there or believing things that aren't true. Do your best to understand where they're coming from, and as long as they aren't in any danger, try not to intervene. Even though you know that what they're seeing is a hallucination, it's very real to them, and saying that it isn't there might just confuse them more. Sometimes, if hallucinations begin suddenly, they can be a sign of infection or a side effect from a new medication. Talk to their doctor if you think this could be the case. There's no perfect solution for responsive behaviors, so use trial and error, and try your best to be understanding. Responsive behaviors are a lot to deal with, but by learning to look for triggers and responding to you're caring for,
inside it's a very valuable video, and I put for you the link here within the PowerPoint slides. You will find it here, so please go back to this video and watch it from the link. You will find it there, and that's not bad. It's a very good video regarding how to deal with the different situations. And we move forward right now, actually, to go into another points of how to deal in such situations, how we will deal with such a case for the case of dementia. So this was about the cases like we said here, and we talk about the early stages and the difficulties in the tree. Just to remind you, touching the person, hugging, holding the hand, or whatever is physically protective should only be used as a last resort. Do not do this, because some people think this is a kind of aggressive behavior. Now let's go to the stages and what you will do in each stage from these stages when dealing with the dementia cases. The baseline, let's go like this, and let me enlarge so you guys can see the everything is written here. The baseline, you have to know the person very well, know their baselines, recognize subtle changes. So make sure that you see this person and make sure which stage is he or she in. Try to find out more information from the family, from the beloved persons from his family about which stage he is in. Second stage is anxious. Now you will identify changes, acknowledge the change, validate their feelings. Validate the feelings because you know that they might change behavior in any moments. Identify triggers, hungry, angry, whatever. Remove triggers, stimuli. Respond calmly with care. Usually, even if you find a shouting or don't think this, the dementia people are always not 100% functioning well. The brain is not functioning. So don't take it in person like what you heard in the video right now. Respond calmly and with care as well. Provide space and privacy. Always use verbal redirection. And also when you talk, just talk slow down, small sentences, repeat what you are saying. This was the second stage. Third thing is the verbal communication, how to do or whatever act will happen. Validate and back off. So in verbal things, like as example, if it has come to just verbal abusing or whatever, validate and back off. Take yourself back. Remain calm. Validate their emotions. Use stop and go. So you can say stop and go. Provide space and privacy. In all the stages, you will provide space and privacy. Remove bystanders. Mind your nonverbal cues and know when to step back. So as long as it's just speech or talking or verbally without going to whatever we said, even now in the sexual abuse, which saw just now, so in that case, it's better to just let him hold something in his hand or her hand, like a bottle of shampoo or whatever, so they don't use their hands in aggressive behavior or harassment. Physical. When it comes to the physical now, come to the physical work or the dementia physically. So you have to minimize the risk. Take a step back. Your safety first, as PSW. Your first is safety is very important. Avoid touch. Stay calm and kind. Use their names. So don't talk to him or say, hey. No, use the name. Give clear directions. Call for help. And use gentle, persuasive techniques in dealing with them. Continued support here in that stage, the recovery. Still, you have to continue the support. Use the reassurance position. Support emotional expressions. Be gently respectful and caring. Be aware of possible re-escalation. Means the escalation might go back. Yes, it's here in the top. So it was the start, then it became verbal, then it became physical, like you see here. So the verbal is a stage before the physical. Physical means touching, punching, trying to hit, and so on. Then they will calm down. They will calm down the stage here, but be aware that this is not the final, because it might go back to the escalation back. So it might go back to the escalation from the start itself here. It will start again. The circle will start again. So it doesn't mean that it came to an end, that this is the end. No, it might be a problem. The problem might repeat it back, because you have, even on the sundowning, you have even long night, and this behavior might change. And I saw this personally in some places, in some hospitals here in Toronto, with dementia cases, and it was also very aggressive. They were very aggressive at night time. They were very aggressive at the night time. As a PSW, I'm saying your safety first. Take the precaution, but don't take it in person, and don't return back. Don't think that you are dealing with a person who is functioning 100%, right? No, this person is having some problems, mental problems and cognitive problems. So he's not in his conscious. He doesn't know what he's doing, or she doesn't know what she's doing. So don't take it in person, like, and you have to return the punch by giving a punch, whatever. No, no, no. You have to be very easygoing, and at the same time keep the safe distance, like what we will see right now. I will show you here. Always consider the whisper zone. Like here, the whisper zone is here in this area. The friend zone, you should make it large. Then this social zone is like this. Then the public zone is here. Of course, you will be, and don't come from behind him or her, or don't come from a side. You should front and talk in person, and talk with name. Don't say, hey, you, this and that. No, talk with names. The position here also, this is the techniques also for escalation and de-escalation strategies. Escalation, like you see, also will lead to a crisis. Signs like kicking, property destruction, self-harm, etc. What to do? Focus on safety first, give space, stay calm, provide reassurance in all. And also the caregiver's escalation. What to do? Control own response, model calm behavior, use non-threatening body language. Don't talk like an aggressive way in front of them, because this will make them agitated more and more. No. Keep a safe distance between you and the patient, and talk in a smart way. So let's go now here for the escalation. Here, the escalation, like we said here, this is the escalation. Like you see here, the curve is moving up from the patient. So the escalation here, the psychological changes, you know, the psychological changes will happen to this kind of the dementia patients. Getting upset, what to do? Identify signs of allegation, redirect, model coping strategies. What the strategies which you will do, like we will see now in the strategies. If it's holding the hand, or holding from the back, or trying to punch, or trying to kick. All this, how as a PSW you should avoid, and how you can deal with such situations. Use humor appropriately. The trigger, like here we said, hungry, tired, because this, the trigger or the problem, the sort of the problem or the reason of the problem, is the one who will lead to the escalation of the situation. So the trigger might be hungry, tired, bored, asked to perform a task, whatever. What to do? Make task more enjoyable. In that case, make task more enjoyable. Like we said, the trigger or the cause of the reason for the anger or the unexpected behavior from the dementia patient will start for any reason, angry, or have hallucinations or delusions or delirium. any reason of these reasons, it might cause him to escalate the situation, especially like when we said sundowning or sundown. When it becomes a little bit dark, things gets worse more and more. So in the escalation, like I said, psychological changes, getting upset, what to do, what you will do. In all the cases, focus on your safety first as a PSW. Give a space. Stay calm. Do not get the anger. Respond to the anger with anger. Do not make it panic. Provide reassurance as well. That is for the escalation. De-escalation. What are the strategies which you can do as a PSW? The escalation started to get calmed down. So what to do? Focus on calming strategies. Do not rehash incidents. So do not get back the incidents to the, just wait till everything calmed down. Stabilization, completely calm. So the start with the trigger, escalation, then it goes into de-escalation stage, then it goes to stabilization. Like here, exactly the curve, when we come to see, started here with baseline, then it goes to anxious, then verbal, then physical, aggressive behavior, then recovery, getting back. Same steps are here as well. Everything comes to an end. Everything comes to an end. De-escalation, and here we will end with the stabilization. Stabilization is completely calm, return back to situation ground zero, or return back to track. And here, show respect and compassion and be a problem solver. That is the things which you have to take. Plus also, like I told you, be in a safe space. Keep in a safe space. Some advices about the behavior to prevent and diffuse responsive behavior. Look for triggers. Triggers means things which make him upset or make her upset, and or unmet needs. Check out, he's hungry, she's thirsty, and so on. And satisfy these needs. We said in this part, as example, the hungry, you give small amounts of food and cut the food into small pieces to avoid the dysphagia or problem in swallowing, and give the food in frequent, little bit small amounts frequently, not as a meal. So as example, if he's eating 3 meals a day, no, just make it small amounts, and each amount, the frequency of this amount is more. Keep the person physically active. Use positive verbal and body language. Don't use threatening or show your anger because of the behavior of the dementia case. He was aggressive with you. That means that you have to return this aggressive way. No, should be calmed down. Address the person by their preferred name. So his name is John. John, talk to him, say John, don't say hey. Give the person space and over control. Like I said, if you feel very risky, like throwing things on you, throwing knives, throwing glasses, or whatever, then in that case, draw yourself back. Draw back strategy. Draw yourself away and keep in a safe distance. Communicate, then you report also to your own supervisor. Communicate honestly with care partners. So be honest, because they can know if this is a real feeling or this is and the feelings, actually, they experience the feelings. So they know very well if you are imitating or you are really having concern and passionate with them. Treat the patient with more passionate and understanding. Like we said here, the whisper area, and do not come from the back of the patient or from aside of the patient. Please confront the patient directly. Friend space is little larger. Social space is little and more larger. And the public space, which is larger space between you and the patient. The third thing is stop and go. Stop and go. Stop whatever you are doing can wait. So you can stop right now. If you find any kind of violence, think, give full individual attention, observe when and how to resume care. So if you find any kind of aggressive, abusive behavior, you have to stop, like here, think, observe the situation, because he will come, or she, the patient will come to calm down. The patient will not be always escalated. No, it will come the curve, like I showed you the curve will go down. And here also, situation from trigger into escalation, into de-escalation, into stabilization. So nothing will stay the same. Here, you have to watch till everything goes down. At the same time, keep a safe distance. And don't provoke or irritate. And don't go and argue with the patient. Don't go and argue with the patient in that case. 4, go. We said stop, third step. Stop and go. So we talk about stop, think, observe, plan. Those are the 4 steps which we talk about. Then here, the go step. Apply gentle, persuasive approaches. We will see now the gentle and persuasive approaches. We'll talk about it in the upcoming part, which means how can I get rid, or how can I get out? How can I find the outlet of the situation? Smoothly, gently, without hurting the patient. Introduce yourself and use respectful communication. Use validation or reality orientation as appropriate. Use reminiscence, parts or art or music. It's like a doll therapy. Minimize distraction and noise. Use the noise which is there, because the noise might be provoking them. Use praise and positive body language. Do not look like you are threatening in return. Like, example, if you didn't stay, I will show you what I will do. No. Don't use these sentences. Or don't show from the body language that you are angry because they abused you or they were aggressive with you. Don't show this. Connect with the person's past. Use visual demonstration on hand over hand. Give brief directions. But here on hands over hand, take care also, because some dislike touching. When you touch, be very careful. Like touching from the hand or whatever, be very careful. Give brief directions, 1 step at a time. Use the reassurance position with palms open. So your palms will be open like this for the assurance position. That's how to deal with the patients as a caregiver or a personal support worker. How to deal with the patients with dementia. And actually, I will go also, and here is another video about these points, because there are a lot of videos. Each video is having its own tactics and how to deal with the cursing or verbal aggression. Let's see this one. Let's go to this one and see it.
Turn that radio.
Ellen,
Dad,
what's the trouble, my dear?
what do you mean what's the trouble? I don't know.
What can we do to make you more comfortable?
Let me out of here.
Would you like to lay down in your bed?
No, I'd like to go. Out,
Outside?
out.
Is everything okay, Lisa? Hi, Ellen.
Why, yeah.
I'm sorry. I didn't mean to touch you. Are you okay?
Oh,
You.
no.
What's the matter?
Oh, nothing.
Nothing?
No.
How come you're talking that way?
Because I don't like them. I don't like them, I tell them so.
Well, that's fair enough. We want to help you. Make
Oh,
you feel
sure,
a little
make
bit better.
me feel at home and everything's happy and it's a real jive, isn't it? Just a jive.
We're here to make you feel comfortable.
Oh, yes, sure you are, I know. Get out of here.
Tony's here. You were calling for Tony.
Where is he?
He's right here.
Last time you wanted to go out for a walk.
Yeah,
It's a beautiful day out there right now.
yeah,
Do you still want to do that?
I still want to do it.
Okay. Okay, but I'll put something a bit warmer on you, okay?
Why?
It's a little cold out there. I can just take you out here on the side, okay?
That's be fine.
Okay. Let me see what you got in your closet. All right. Well, I'll just put that over you and we'll go out inside there. How's that?
I guess that'll be all right.
Okay.
You know what I'd like to be doing?
What's that, kid?
walking about with a rake. You know, I like to do things like that. That's what I like to do.
Well, I can't give you a rake, but I could take you along the grounds here if you want.
Okay.
That's good enough. That's second best, eh?
Yeah.
We're gonna go this way. Can we get you something to drink?
Yes, I'd like a scotch and water.
Well, we haven't quite got that, but something close though. Tea.
Oh, yes. God can help me.
You want tea?
I sure would love tea.
Okay, I'll get it for you.
So, like you saw here just now, we have many stages. Cursing or
Yeah,
Ellen,
that was a trouble.
what can we decide?
Ow.
Is everything okay? I'm sorry.
Oh, nothing. No,
How come you're talking that way?
because I don't like it.
so here is the stage of the stop, the stage of the stop, then engagement in meaningful activities, then here we go into listening to residents' perspective. Just listen to what they are saying and take care. Your body language must be empathy with what they are saying and show the interest in what they are talking. Then give compromising as example for some kind of behavior. Then here is the redirecting at the end. Redirecting, but putting a kind of behavior. Here it is, the redirection, like showing something else they can do, like should I bring you for a cup of water or drink or whatever. That is will help also in that case. We have here a strategy for dealing with the cases of dementia and how to deal with cases of dementia. We'll see, we'll watch also. I put for you the link of the video down, and also we'll see for more and more. Like here, let's see this one about how to handle the aggression. How to handle the aggression.
A nurse working with 24-hour home care, and we are here in Goodwill, Long Beach. I'm going to go over several strategies on how to deal with aggression. So sometimes in a patient setting, they have mental diagnoses that include, but are not limited to Alzheimer's and dementia. So in this case, sometimes they are fatigued, sometimes they are hungry, they are trying to communicate how they feel or what they want, and they simply cannot. So
that's what we call the triggers. That's what we call the triggers. Triggers mean the reasons for their violent behavior. The reason for their violent behavior. Here we go. This is the reason for the violent behavior. They are okay. And this will lead to the escalation of the situation. The escalation means the patient will start to get angry in an angry mood, like what we see right now.
It becomes very frustrating. Your job as a caregiver is twofold. Number one, to de-escalate the aggression, de-escalate the anger, and while simultaneously trying to find out what it is they want, trying to find a solution, and making it so that they are not a danger to themselves, not a danger to others. So right now we're going to demonstrate someone who's in a very agitated, borderline aggressive state, and I'm going to demonstrate how to not only verbally de-escalate them and keep them calm, but also I want you to pay attention to where my hands are, where my body positioning is. It's not an aggressive or violent indication, but it's more of making sure that they're not a danger to themselves and a danger to me. At the same time, I'm going to try to find out what it is that they in fact do want, this thing that they're trying to communicate, because they are usually trying to communicate something. And if they can't do it, it is up to you to go through a process of elimination to see what it is they want. Oh, Mr. Gonzalez, you okay?
Whoa.
okay.
Please leave me alone. I
It's
just
okay.
want to go outside.
You don't need the belt. You don't need the belt. How about this? Let's.
No, I'm
You want
not
some water?
listening. No,
You want some water? How about a
I can
bagel?
go.
Want some apple juice? You want some apple juice?
You have apple juice?
I can give you some apple juice.
You have.
See the distraction or redirecting now? It's telling him you want an apple juice, or just redirecting is to another attention, or making him pay another attention to something else.
Give me apple juice.
I can absolutely give you apple juice.
You have apple juice.
It's right here. Just take a look. It's right here. So in that situation, I prevented him from being a danger to himself. I wanted to make sure, even though I wasn't holding his hand, I was making sure that the belt was away from him and away from the hardest point of contact when you're swinging an object, which is the end of the object. I wasn't threatening him. I was searching for solutions for things that he could possibly want. I asked him if he wanted water. That didn't work. I asked him if he wanted a bagel. That didn't work.
So the redirection based on the triggers, which the reason for the violent behavior. He's looking for something to satisfy him and to meet his needs, to meet the patient's needs.
I asked him if he wanted apple juice, and I could see that he had a positive reaction to the apple juice, and so I just went with that. And you'll notice another thing too, that he was asking repeatedly, so you have apple juice? So you actually do have apple juice? It's very important to establish trust with these patients, and so do not claim something that you actually do not have. I knew that I actually had what he wanted, which in this case was the apple juice. So I used that as the de-escalating factor in this case. Several things were accomplished. He's no longer a harm to himself. He's no longer a danger to others. He has what he wants, and that's one example of a strategy to deal with aggression. For more,
this is I put for you the link here on the here it is. Copy, and I will put it for you here inside your own. So you guys go for this link. It's a wealthy video about this point. We had an idea today on how to deal with the progressive behavior of the dementia cases, and we knew how to deal with these patients. Let me remind you back with what we talked about before. Trigger, look for the reasons behind the behavior. It moves into escalation from the patient side, start to escalate the situation. Then you have to deal with the escalation here as a personal support worker or caregiver. You have to deal with the situation, like as example, like if you're kicking or destruction for the property needs, or self-harm, or trying to punch the personal support worker, or whatever. Then what to do? First of all, focus on safety. And by meaning of safety, keep a distance between you and the patient in that case that allow you to go away if the violence increase. Stay calm and provide reassurance. Also, you have to control on response. You have not to go on a fight with him. And use the model calm behaviors. In the stage of de-escalation, because the patient will go down, will calm, you won't stay always escalated like this. Focus on the calming strategies, do not rehash the incidents. In the stabilization strategy phase, that will be completely calm. He will be like started calm, he will return back to be calm. Show respect and compassionate, always positive listener. As a PSW, you have to be a passionate and positive listener to what he's saying. And you have to be a problem solver as well. That was in dealing with how the personal support worker in general deal with the dementia cases. So here, I will take it just a question like this, and I will go, guys, here right now after we finish this part. And I will just put it as a question, a new slide. And this is our question right now before we move into next part. What are the PSW basic rules with dementia cases? What are the PSW's rule with the dementia case? What he will do in cases in behavior changes. Of course, with dementia cases regarding what? Regarding behavior changes. Regarding, here it is, regarding behavior changes. Regarding behavior changes. So what he will do, what the person support worker will do when there is regarding the changes in the behavior. Shall say like around 5 minutes to take your answer, guys. Only like around 5 minutes to take your answers in this part, and then I will get back to you. Thank you. So please answer this question, guys. What are the PSW basic rules with dementia cases regarding behavior changes? This is the question now. We'll stop here like around 5 minutes before we move to the next part.